So, to have a brief introduction, I'm going to speak today on bilateral superficial thrombophlebitis in COVID-19 infection. Myself is Dr. Sunita Kumbhalkar. I am working as professor in general medicine at All India Institute of Medical Sciences. I am very much thankful to my whole department, including my head of the department, Dr. Joshi, our director, Madam, Dr. Vibha Datta, and all my other colleagues. Okay, can you see my second slide?
Yes, doctor, we could see.
So, my first case is a 32-year female. She presented to us with a right hemiparesis and dysarthria. This patient actually was admitted outside for a few days with complaints of some neurological weakness, and then from that hospital she was transferred to us. She has on admission the pulse of 130 beats per minute. She has a BP of 100/60. Her respiratory was 20 and the SpO2 was 99% on room air. On examination, she has right radial, ulnar and the brachial pulsations were absent. She has evidence of right supranuclear facial paresis with grade 3 power on the right side. So, thinking to be a case of neurological weakness with cerebrovascular episode, we investigated this patient. Her MRI brain showed multiple small foci of restricted diffusion with matching ADC dropouts seen in the right parietal, subcortical white matter regions, anteromedial part of the left thalamus, superior part of the cerebellum, suggestive of periembolic phenomena or perivasculitis with again acute lacunar infarcts, diffuse mild areas of restricted diffusion with no significant ADC drops and which are appearing hyperintense on the T2 weighted image and the stir images, as well as some conglomerated rim enhancing lesions within it, which is again suggestive of left parietal region side of the subacute infarcts. So she has both the acute lacunar infarcts and the subacute infarcts also. Her intracranial angiography was done as evaluation. It was normal. So these are the imaging of this case. We showed she has a lacunar infarct in the parietal region and some also areas in the gangliocapsular region also. So with this presentation, as she came to us in a COVID situation, we did her WBC. It was normal. Neutrophil count was 77%. Her platelet count was normal. C-reactive protein was raised 17.9 milligram per liter. ESR was slightly higher. As she presented as a young patient with cerebrovascular episode, we did her thrombophilia profile, which was normal. Her ECG shows T-wave inversion in the inferior leads with a normal LV ejection fraction. So, in hospital course, she had no history of fever, cough, breathlessness, or diarrhea, which usually suggests the symptoms of COVID-19 infection. She was treated with antiplatelets, statins, low molecular weight heparin, and other supportive treatment. When she came us as a second week in her hospital stay, she developed pain and swelling and the redness of both the lower limb, despite being on a low molecular weight heparin and the LMWH and antiplatelets. There was no history of any lower limb venous cannulation, any venipuncture, prolonged immobilization, because she has a power of about grade 3. She was moving her limb, no history of varicose veins, any trauma, or taking oral contraceptive pills. Her gynec and obstetrical history was uneventful. So, in view of the clinical presentation, because she has a right-sided upper limb pulsations were absent, she presented with a cerebrovascular episode and the lower limb, both swelling and the erythema as a evidence of venous thrombosis. We had the suspicion of COVID-19. Her COVID-19 PCR was done and it was turned positive. Her post-COVID functional status during the hospital stay was grade 2. Her imaging was done. We did for the evaluation of her venous thrombosis and the arterial thrombosis. The upper limb arterial Doppler is showed there was no flow in the right ulnar artery along with the course of the ulnar artery representing thrombosis, while both upper limb venous Doppler was within normal limit. The lower limb venous Doppler shows acute thrombosis in the right distal femoral vein up to the adductor canal, extending into the popliteal vein with poor reformation of the anterior tibial and the posterior tibial vein. There was a short segment occluding the subacute. It was iso to hyperechoic thrombosis of the left popliteal vein. There was also partial thrombosis of the left greater superficial vein and the short segment up to the mid thigh. So chest X-ray, she has evidence of some patchy consolidation. So thinking to be of her lower limb venous Doppler. So you can see in the venous, this picture, you can see the compression and the flow in the venous system, which suggests of the thrombosis of this area. And she presented with the swelling simultaneous of both the lower limbs as a clinical presentation after the episode of her cerebrovascular episode. So laboratory findings were her WBC count was 29,000 at this presentation. NLR was more than 3.5. Her C-reactive protein was 13.34 milligram per liter. D-dimer was highly raised to 247.2 nanogram per ml. LDH was high. IL-6 was also higher, like 63.89 picogram per ml. And this patient, actually this hemoglobin HPLC was done after her episode of this was over, and she turned out to be sickle cell trait. So patient was followed up during an hospital stay. She was recovered of both the cerebrovascular episode and also her venous lower limb edema. It has also disappeared, decreased. After the on follow-up after 15 days, repeat venous Doppler of the lower limb showed partial resolution with a clinical recovery and disappearance of the edema bilaterally. During this follow-up, we also did CT pulmonary angiography and the CT aortogram. It shows partial acute thrombosis of the main pulmonary artery extending into the segmental branches and the subsegmental branches of the upper lobe branches. So this again suggests you of the pulmonary arterial embolism at the same episode when she presented with the cerebrovascular episode. So partial thrombosis also noted in the main right pulmonary artery extending into the lower subsegmental branches. So just to again confirm that she has the episode of pulmonary embolism also with the cerebrovascular episode during her index admission. So this picture clearly shows there is a main pulmonary artery and there is a evidence of the pulmonary artery, right pulmonary artery. The filling defect is shown, which suggests again the right pulmonary artery embolism. Again, here also we can see the defect in the pulmonary artery. Also, we validated her other imaging with the abdominal system examination, and she also had the infarct in a kidney. These are the kidney regions, and she has some infarcts peripherally, and also she has an infarct reported in the spleen also. So follow-up, she has a good functional status. On follow-up, the patient was continued on oral anticoagulant and antiplatelet, and it is still under follow-up. So this is my first case, a female patient presented with venous bilateral superficial thrombophlebitis and manifested earlier with the arterial thrombosis and the pulmonary embolism. The second case is a male patient, 32-year male patient, young patient. He presented to us with the swelling, pain, redness of the both lower limbs simultaneously. He had history of cough for the past 2 days. There were no other symptoms suggestive of the COVID infections like diarrhea or breathlessness. He was also non-hypoxic during his index admission. This patient again admitted during the second wave of the COVID. We investigated thinking to be high possibility of the COVID infection as a cause of superficial again thrombophlebitis, as we had a prior experience of one case. Her INLR was more than 3.5, CRP was 53.75, and D-dimer also was high, more than 1000. The venous Doppler was done. We suggested bilateral lower limb complete thrombosis of the great saphenous vein for the entire length in the leg, and complete thrombosis of the greater saphenous vein for the entire length in the leg, suggestive of the superficial venous thrombosis. So on examination, these are the patients. He has a bilateral lower limb simultaneously present with the lower limb. There was a swelling. There was a typical patchy discoloration of both the lower limbs. The venous Doppler, it shows again the non-compressible vein in the lower limb, and there was a fat straddling, and here you can see there is a no venous Doppler flow. There is a no flow in the greater saphenous vein, again suggestive of the superficial venous thrombosis. So on examination, we did his COVID test. It turned out to be positive. As a young patient with venous thrombosis, we did the serum anti-nuclear antibody test, beta-2 glycoprotein IgG, IgM, which were normal. CT thorax revealed few nodular opacities. CT abdomen was done, maybe a cause of, thought to be a cause of, it is some pancreatic tumor. The abdominal CT was abnormal. Patient was treated with the low molecular weight heparin for a period of 5 days. There was complete recovery of the swelling in 1 week, and the patient was given a 6-week period of the dabigatran on the follow-up discharge. So this patient also has a complete recovery after his primary index illness. So here I presented 2 cases of the superficial thrombophlebitis. In literature, there are very few cases of a superficial venous thrombosis. We have many reports of the pulmonary embolism or the deep venous thrombosis. So that's why I take a privilege of presenting these 2 cases, that to bilateral during the index admission. So just a word about the COVID. You know, COVID has Indian figures. They have crossed millions of number, and the deaths also more than 5 lakh days they are there as of November 22. These are the Indian figures. And you know, initial there is a viral phase followed by the host immune reconstitution phase. So earlier we get a normal routine lab test, mild lymphopenia, normal blood gas analysis. In a phase of mild to moderate disease, there is an increase in lymphopenia, mild increase in prothrombin time, D-dimer, increase LDH, and there is a mild hypoxia, SpO2 more than 92%. As the stage progresses towards the host immune response, when it manifests, it goes to a more severe variety. There is a progressive increase in D-dimer, ferritin, increased transaminase, triglycerides, abdominal ABG, and you get mild increase in the NT-proBNP, more increase in IL-6 and C-reactive protein, and then there is a reduction in the platelet count, and there is a progressive hypoxia. While in the critical phase, there is a progressive hypoxia with all marked elevation of all the markers of inflammation. So what is the pathogenesis of vascular events in COVID-19? You know, the SARS-CoV infect endothelial cells through the SE receptor 2. This SE2 is downregulated, promoting an imbalance between the SE2 and the angiotensin in favor of angiotensin 2. This infection disrupts the endothelial cells. all pericyte crosstalk is there, contributing towards the endothelial cell dysfunction. Activated macrophages release various cytokines, causing immune-mediated cytokine storm, which is a more disastrous. This vascular inflammation, which is known as a endothelialitis, which causes increased vascular permeability and all cascades of other consequences. So this again, the algorithm shows how COVID infection, because of its hypercoagulability, then second causes sepsis-induced hypocoagulopathy, that is SIC. Later on is a disseminated coagulopathy and the macroangiopathy. So it's a cascade like immune system mediated complement activation, cytokine storm, which causes hemostatic derangement, hypoxia mediated, all TNF alpha, PAI1, increased fibrinogen, D-dimer increase, which causes the pulmonary related coagulopathy. So there is a pulmonary hypoxia, vasoconstriction, pulmonary hypertension, right ventricular failure. Then in other arm, it causes the extrinsic coagulation pathway involving monocyte, neutrophil. There is a cell apoptosis and a immune mediated complement activation. Another direct viral mediated pulmonary endothelial dysfunction, that the endothelialitis that I described. Cytokine mediated complement activation, there is another lectin pathway. Then there are other, all these coagulation factors, mechanical ventilation support, immobility, again all these again contribute to the hypercoagulated states. The important are the comorbidities associated that we came to know in our COVID situation, like malignancy, other hypercoagulated states, obesity, pregnancy, liver dysfunction, maybe because of drugs what we use, and the nutrient deficiency. So it is a multifactorial hypercoagulated state in a state of COVID-19. So I described this endothelitis, right? There are the microthrombosis in the pulmonary capillaries and fibrin and the RBC deposit in the cells. Then what is the mechanism of there is a sprouting angiogenesis, the newer vessel, the sprouting, and the intersusceptive angiogenesis. So all these mechanism, it contributes to the mechanism of vascular disruption. So how to work up a case? A patient in the COVID-19, we have to obtain the baseline PT-INR, D-dimer, we have to do fibrinogen platelet counts. After that, we have to assess the bleeding risk, low and the acceptable bleeding risk, encourage mobilization plus thromboprophylaxis. If there's a high risk of bleeding, mobilization, sequential compression, we have to hold the thromboprophylaxis. So active routine screening for the venous and the arterial thrombosis should be done. In the ICU setting especially, we have to screen, all the duplex sonography has to be done, ultrasound has to be done. We have to have a clinical radiological surveillance, then D-dimer estimation, and we have to consider the therapeutic anticoagulation. So whether to transition to the either VKA, oral anticoagulants, or unfractionated use of heparin, or the newer antiplatelets or the anticoagulants on discharge. So we have to take individual case in his own perspective, and we have to treat accordingly. So here I presented two cases. In literature, it has been shown that as such a superficial thrombophlebitis, there is no treatment is needed. Okay, some treatment of risk factor, and these cases are only symptomatically has to be managed. We don't routinely start heparin also in those cases, but in these cases they were post-COVID. That's why we treated this patient with the short-term course of the unfractionated heparin, and later on for a short course we gave them the dabigatran also with a complete clinical recovery. So what are the learning points from this case? COVID-19 infection is suspected of inducing a hypercoagulated state, resulting in all the pulmonary or the macrovascular thrombosis in both the arterial and the venous system. Extensive bilateral venous thromboembolism in COVID-19 can be found regardless of the respiratory symptoms. So here both cases did not have the respiratory involvement. There was a SP2 was maintained normal on room air. So irrespective of the severity of the respiratory symptoms, irrespective of the age and the comorbidities and the risk factor, The timing of the onset of the venous thromboembolism is again variable. It may range from even the first day of hospitalization to the 5th week. As our first patient, she presented late to us. Although early onset seems to be more frequent, as the case was the second case which presented to us. So my one case, it presented with a sickle cell trait. Sickle cell trait is considered to be a benign condition, but in a setting of COVID, there were more chances of the thromboembolism, as our case presented with a pulmonary thromboembolism also. Duplex ultrasound screening program should be organized for suspected thrombosis in confirmed COVID-19 cases in hospital patient based on the clinical evidence. Then longer follow-up periods may be available so as to provide more complete picture in the course of VT in COVID-19 infection, especially if you want to see the response to anticoagulation. So these are the references. So thank you for your patient hearing. Any questions are there? I'm ready to take the question.